This unit covers malaria case management interventions in elimination settings. By the end of this unit, you will be able to explain case management adaptations along the transmission continuum, explain the difference between sensitive and specific suspected case definitions, specify the 2 diagnostic methods recommended for elimination settings, and understand and describe the reasons why a single low dose of primaquine is used for Plasmodium falciparum in elimination settings.
Let's begin by understanding the role that case management plays in malaria elimination.
Case management is needed to reduce illness and death from malaria and other diseases that may have symptoms similar to malaria. It also plays a role in the surveillance of malaria for elimination and in the surveillance of drug efficacy. What does case management involve? Broadly, case management can be divided into 3 areas: diagnosis, treatment, and follow-up. Across the transmission continuum, early and accurate diagnosis of malaria is essential for effective disease management and malaria surveillance. High-quality malaria diagnosis is important in all settings, as misdiagnosis can result in significant morbidity and mortality. Demonstration of the presence of malaria parasites through parasitological diagnosis before treatment with anti-malaria drugs is fundamental, as the accuracy of clinical diagnosis using symptoms alone is poor. Parasitological diagnosis is important in many settings to differentiate between malaria species in order to ensure that the appropriate anti-malaria treatment is provided. Parasitological diagnosis also identifies patients whose symptoms are caused by something other than malaria and who need to be assessed for other causes of illness. All patients need appropriate treatment, whether for malaria or another cause of their illness. Patients who present with symptoms similar to those of malaria but test negative for the infection need to receive additional assessment and appropriate treatment for their illness. Patients with confirmed malaria infections require rapid treatment with an effective and quality-assured anti-malaria to ensure cure and prevent further progression to complicated or severe malaria. For patients with Plasmodium vivax and Plasmodium ovale, there needs to be additional treatment with a drug that can rid the liver of hypnozoites, as we learned in Unit 2. In area approaches elimination of Plasmodium falciparum, it is recommended that patients also receive a single low dose of primaquine to reduce the transmissibility of the infection. Patient follow-up is important to ensure that the cure has been safe and effective. Patient follow-up is also important to monitor the continued efficacy of the approved treatment regimen in the country or area. In elimination settings, case management takes on some additional objectives on top of those in high-burden countries. The primary objective of case management across all malaria programs are to cure disease and prevent complications and death. In elimination settings, there is additionally the goal of preventing onward transmission from individual cases. This is accomplished by ensuring a complete cure of patients through early identification of suspected cases, correct diagnosis, supervision of appropriate treatment, and follow-up of all cases in the appropriate time frame for the anti-malaria medicines and parasite species to ensure cure. Onward transmission is also reduced through the provision of a single low dose of primaquine for Plasmodium falciparum infections in order to reduce the transmissibility of the infection. In elimination settings, good case management can also reduce the size of the parasite reservoir by providing supervised treatment, including radical cure for Plasmodium vivax and Plasmodium ovale, in which a full course of primaquine is given based on the patient's G6PD deficiency status. Providing a full course of primaquine to clear the liver stage parasites reduces the chance of a future relapse and the chance of onward transmission. This slide depicts the key aspects of case management that change along the transmission continuum. The start and end points of each element are indicative rather than prescriptive, as they are intended to illustrate the changes that should take place as transmission declines. The goal for all case management is to provide universal access, that is, for everyone who needs it, to early, quality-assured diagnosis and prompt effective treatment with the objective of reducing morbidity and mortality. Effective case management prevents serious morbidity and death across the continuum. In areas approaching elimination, case management takes on additional objectives related to interrupting transmission. As no set of science or system consistently predicts malaria infection, it is impossible to identify a suspected case definition that will apply at all times and to all areas. However, most high-burden areas use fever, history of fever, or palmar pallor to trigger a malaria diagnostic test. In elimination settings, if resources are available, all cases of fever in receptive areas should be tested for malaria. However, if resources are limited, the National Malaria Program should try to identify a case definition that balances the cost of testing and the possibility of missing a case. Many countries seek to achieve this balance by testing only cases of fever in people who report recent travel to malaria endemic areas, even within the same country, along with cases of fever of unknown origin after exclusion of more likely causes of fever. An effective anti-malaria medicine should be used. WHO pre-qualifies medicines for treatment of malaria, and guidelines differ by parasite species, as we will learn in this module. Radical cure for hypnozoites is needed in the case of both Plasmodium vivax and Plasmodium ovale. WHO recommends the addition of a single low dose of primaquine for cases of Plasmodium falciparum in areas with low, very low, or zero indigenous transmission. Single low-dose primaquine can clear mature parasites and prevent onward transmission from Plasmodium falciparum infections and can be administered without the need of G6PD deficiency testing. All currently recommended anti-malaria medicines require multiple days of treatment. It is vital that patients are sensitized to the need to take all doses at the appropriate intervals and in appropriate manner. In elimination settings, direct supervision and documentation of treatment is recommended to reduce the risk of incomplete treatment, which could contribute to continuing transmission while also being potentially damaging to the patient's health. Many eliminating countries hospitalize their few remaining malaria cases to ensure adherence to treatment and complete cure before they are discharged back to their home. In elimination settings, it is recommended that patients be followed for an appropriate time period, depending on the parasite species and anti-malaria medicines, to ensure that the infection has been cured and to ensure there is no onward transmission. Understanding whether the medicines provided to treat malaria infections are effective is an essential component of case management systems. In high-burden areas, therapeutic efficacy studies are usually undertaken in sentinel sites. However, when transmission declines, it is no longer possible to gather enough cases of malaria in one or several health facilities to conduct traditional therapeutic efficacy studies. At this point, data from the surveillance system should be used to monitor drug efficacy. We will cover integrated drug efficacy surveillance systems later in this unit. Let's quickly review the steps that need to happen for a patient to be appropriately diagnosed and treated. We will then focus on the specific steps of the process. When a person who is ill has access to the health system, whether at a health center, with a community health worker, or through active case detection, it is critical to recognize that the patient could be infected with malaria. At this point, the patient becomes a suspected malaria case. The method of identifying suspected cases may differ by health center or hospital, and could be through passive or active case detection. But generally, the health workers attending the patient should be instructed to identify all patients who meet the suspected case definition for malaria. The suspected case definition is a set of symptoms and other risk factors that have been defined by the malaria program for the country or area to help identify those people who should be tested for malaria. All suspected malaria cases should be tested using a quality-assured parasitological test. WHO recommends either a WHO pre-qualified rapid diagnostic test or microscopy to diagnose malaria cases. We will review these two methods in more detail later. A positive test should be followed immediately by treatment with a recommended anti-malaria medicine. In elimination settings, treatment should be supervised by medical personnel to ensure adherence to the full treatment course. If the test result is negative, the patient must be assessed for other causes of illness and treated appropriately for the other causes. Patients who test negative should not be given anti-malaria. Arrangements must be made to see the patients who test positive for malaria at predefined intervals. These are at minimum on day 28 or day 42, depending on the drug, and at least 3 months for Plasmodium vivax to identify potential relapses. At this follow-up visit, the health workers must assess whether the patient has been fully cured of their malaria infection through microscopy.
One of the most critical steps in elimination is for the health system to recognize a patient who might have malaria. As recognizing a suspected malaria case is not straightforward, we'll spend a few minutes reviewing the process.
In the previous slide, we talked about how it is important for healthcare workers to recognize patients who might have malaria and send them for testing. A suspected malaria case definition identifies signs and symptoms of illness in a person that could indicate a malaria infection. Additional characteristics that can help to identify suspected cases include where the patient has stayed during the likely period of infection and other factors that might have increased their exposure to malaria-transmitting mosquitoes. The suspected case definition is usually described in the national or regional surveillance or case management guidelines. All health workers who could potentially identify suspected cases should be trained in application of the definition, and refresher training on the topic needs to be conducted at regular intervals. Training and retraining are particularly important as malaria declines and begins to fade from people's minds. The suspected malaria case definition might be different in active case detection. If the objective of active case detection is to identify clinical cases, then the suspected case definition will be similar to what would be used in a health facility. However, if the objective of active case detection is to identify febrile infections, then the suspected case definition may only include identified risk factors such as recent travel or residence near a confirmed cases to guide who should be tested for malaria.
Malaria causes a range of signs and symptoms as described in Unit 2. As mentioned earlier, there is no predefined set of signs or symptoms that always predict malaria or always rules it out. Fever or history of fever is one of the most common signs of malaria, but there may be other symptoms such as shaking, chills, headache, muscle aches, or tiredness. Nausea, vomiting, and diarrhea may also occur. Malaria may also be the underlying causing of anemia and jaundice because of the loss or suppression of red blood cells. If there are sufficient resources, all persons with any of these signs and symptoms should be tested for malaria in a country working to eliminate malaria. For instance, everyone with fever or history of fever should be tested for malaria. This would be a very sensitive case definition and is likely to capture most malaria cases. In elimination settings, you may want to have as sensitive as case definition as possible, because missing a positive case could cause a setback in achieving the elimination goal. The drawback to a very sensitive case definition, however, is that you will use a lot of resources to test many people who do not have malaria. If resources are limited, then the suspected case definition needs to be modified to make it more specific and less sensitive. Since there is little malaria locally in elimination settings, the suspected case definition should include history of exposure to malaria, that is, overnight stay in a malaria endemic area before the incubation period of infection. This malaria endemic area could be within the same country or in another country. Everyone with signs and symptoms of malaria and travel to malaria endemic areas during the likely period of transmission should always be tested for malaria. Finally, a suspected case definition must be clear and easy to apply for those using it. For instance, if a suspected case definition includes a long list of potential signs and symptoms, it is not likely to be used very often. In the end, sensitivity, specificity, and ease of application must be balanced when developing a definition of suspected malaria. Let's review how the sensitivity and specificity of a case definition can change the number of tests that are conducted and the likelihood that a positive malaria cases will be found. This slide shows people who have come to a clinic because they are feeling ill. Some of these patients have malaria, but most do not. We have decided to use a very sensitive case definition. A sensitive case definition may be one based on fever, which could be determined through history of fever from the patient or body temperature measurement over 37.5 degrees Celsius. Our case definition is illustrated by this red circle, and everyone whose symptoms match with the case definition will fall inside the circle. If we have a very sensitive case definition, such as fever, then we will end up finding almost all the malaria cases in the box on the left. However, we will also include a lot of people who have fever that is not caused by malaria in the box on the right. We will test them, but find that they do not have malaria. Their fever is caused by something else, and we will need to evaluate them appropriately to determine the cause of their illness. This unnecessary testing for malaria could deplete our testing resources. If we use a less sensitive but more specific case definition, such as fever, plus history of travel to a malaria endemic area and overnight stay within the period of 30 to 7 days before appearance of fever, we will test fewer people. We will miss some true malaria cases, but we will test very few people who end up not having malaria. Ultimately, the definition of suspected malaria must balance the requirement for sensitivity, that is to detect all cases, with the need for specificity to avoid testing too many people who do not have malaria and depleting resources. The tricky part in elimination settings is finding the right balance in the definition of suspected malaria.
Let's discuss potential suspected case definitions for two different areas and then see how we might make them more or less sensitive or specific. In the first scenario, the woman and her daughter on the left live in an area of moderate to high malaria transmission, where more than 2,000 cases were reported last year. The area is surrounded by other malaria endemic countries, and as a result of the moderate to high transmission, most of the cases are in children. By contrast, the woman and her daughter on the right live in an area that had very low malaria transmission for the past 2 decades, and only 20 cases were reported last year, most of which were imported because this area is located near a country that is malaria endemic. Because most of the cases were important and there is a low level of transmission, most of the cases were in adults. Starting with the area where the woman and her daughter on the left live, what would be good suspected case definition for malaria? What would be a good suspected case definition for the area where the woman and her daughter on the right live? In each setting separately, what could you do to make your suggested case definition more sensitive, more specific? How easy will it be to implement your suggested case definitions?
The next step after a patient is suspected to have malaria is to perform parasitological testing to confirm malaria diagnosis. All cases of suspected malaria should have a quality-assured parasitological test to confirm the diagnosis. WHO recommends two approaches for testing for malaria: microscopy remote stained blood slides and antigen-based rapid diagnostic tests. At present, molecular diagnostic tools based on nucleic acid amplification techniques such as LAMP or PCR do not have a role in the clinical management of malaria or in case-based surveillance. Regardless of whether microscopy or OpenWHO are used, tests should be available within a short time of the patient presenting to ensure that they are not lost to follow-up and are properly treated so that their disease do not progress to severe illness and that onward transmission is prevented. Only patients testing positive for malaria should receive anti-malaria treatment. If the patient tests negative, they should be reassessed to determine the cause of their illness and ensure appropriate treatment is administered. However, if a patient with severe disease compatible with severe malaria initially tests negative and malaria is strongly suspected on clinical grounds, parasitological tests can be repeated at 6 to 12-hour intervals. Only patients with severe disease compatible with severe malaria and no immediate access to pathological diagnosis should be treated immediately with an antimalarial without waiting for test results to prevent death due to malaria. Microscopy has been used to diagnose malaria since Laveran first identified the malaria parasite in Algeria in 1880. Microscopy is a powerful diagnostic method enabling the direct visualization and quantification of malaria parasites. Expert microscopists can detect parasite densities between 40 and 100 parasites per microliter. Expert microscopists are also skilled at differentiating between malaria species. The equipment requirements include good quality microscope, a light source, clean glass slides, and quality staining reagents, as well as supplies to take safe blood samples. Microscopists must undergo rigorous training and participate in a quality assurance program to be able to prepare, stain, and read blood slides. Maintaining high-quality microscopy skills over time in elimination settings is challenging because the number of positive slides will decline. This, however, can be mitigated by ensuring that malaria remains part of the initial training of laboratory personnel and that refresher training is provided routinely. RDTs are immunochromatographic lateral flow devices that rapidly detect malaria parasite antigens from a drop of blood taken from a fingertip. 3 antigens are used currently. Histidine-rich protein 2 is specific to P. falciparum. Plasmodium lactate dehydrogenase can be used to identify all species of Plasmodium to detect P. falciparum, P. vivax, as well as to distinguish P. falciparum from non-falciparum species. And aldolase provides a test for all Plasmodium species. RTTs have a similar limit of detection as microscopy between 100 and 200 parasites per microliter. And when products are tested by WHO for qualification, they must be sensitive at this limit of detection. RTTs do not require specific equipment, although supplies such as gloves, lancet, alcohol wipes, pipettes, and buffer solutions are needed. Additional advantage of using RTTs over microscopy include a shorter training period, shorter time to results, about 15 to 20 minutes, and more objective interpretation of results. Because of these properties, additives have revolutionized malaria diagnosis and treatment in health centers around the world. While some of the early additives had problems with accuracy, the performance of additives for both falciparum and Plasmodium vivax has improved over time, as we'll see on the next slide. However, there remains some limitation in the detection of Plasmodium ovale and Plasmodium malaria, and there are currently no additives that can distinguish Plasmodium noresci. You have had the chance to consider the pros and cons of microscopy in additives for malaria elimination. Let's briefly review the advantages and disadvantages of each method. In nearly all cases of symptomatic malaria, examination of thick and thin blood films by a competent microscopy will reveal malaria parasites. A competent and well-trained microscopy can differentiate between all 4 human parasites, which is important for treatment considerations. Direct visualization of the parasite and knowledge of the average number of white blood cells in the blood enables counting of parasites and calculation of parasite density, which may be important for treatment. Microscopy can be used to monitor patients' response to therapy or ensure they have been cured of infection. Slides also provide permanent records and long-term confirmation of diagnosis. There are clearly defined and well-established quality assurance and quality control activities to ensure high-quality results. The slides prepared and stained for microscopy can be preserved, which enables re-examination and confirmation of diagnosis if needed, and an opportunity for quality control. However, there are also several important disadvantages to microscopy for malaria diagnosis and elimination. It requires highly trained and well-supervised technicians, which can be challenging in many countries given the distance and cost of supervision. The equipment is costly and often difficult to use in field settings. Electricity is required for a light source. It takes more time to read a blood slide than it has to conduct an RDTs, and the interpretation of microscopy can be difficult, particularly the calculation of parasite density. Microscopy requires a robust quality assurance system, particularly in elimination settings, as the competence of technicians can easily be lost as caseload decrease and opportunities to read positive blood slides dwindle in the absence of an established system of pressure training and quality assurance. Now let's discuss the advantages and disadvantages of additives. The positives for additives are quite clear. Less training is needed for someone to become proficient in preparing and reading additives and to arrive at an accurate result. Additives have a high level of sensitivity and specificity when parasite density is above a threshold of around 100 to 100 parasites per microliter. This means that the tests are highly accurate when used in a clinical setting. Additives can be performed in the field. They do not need to be conducted in a laboratory or by lab technicians. No electricity is required. The interpretation of the additive results requires less technical skills and is more objective than with microscopy. Additive results are returned much more quickly than microscopy results. Now, for the disadvantages. Additives are qualitative tests. They tell you whether a person is positive or negative for malaria, but they can tell you the density of the parasite infection. The antigen used for the additives, particularly the HRP2 antigen, can be detected for a long time after the infection is cured. So this test can be used to monitor patients' response to treatment. In the last few years, we have started to detect parasites that have deleted the HRP2 gene. Additives on HRP2 may provide false negative results when such parasites are causing the infection. WHO, partners, and countries are monitoring the situation to ensure that steps are taken to minimize the impact of HRP2 deletions, and the industry is prioritizing the development of new tests that are not HRP2 based. Additives do not provide permanent records, as both negative and positive tests may change over time.
We are going to divide in two teams, one pro rapid diagnostic test and the other pro microscopy for diagnosis of malaria in peripheral clinics. You will prepare for a short debate on which is the most appropriate method. We will randomly choose one team to start. You will have 2 minutes to argue for your methods and against the other. Then the second team will go. They will have 1 minute to refute the opposing team's arguments against their method and 2 minutes to make their own points. I will decide which team wins the debate based on the quality of the argument for and against.
WHO recommends both microscopy and RDTs for malaria diagnosis, but there are some considerations for where each should be deployed. At hospitals, the highest level of care, microscopy should be the predominant method to diagnose malaria because of the need to determine the infecting species and to monitor the clinical course of infection. However, RDTs could be used for an initial screening or for periods when laboratory personnel are absent. Microscopy should also be the main diagnostic method in all laboratories. At peripheral health facilities, particularly those without laboratories, RDTs may be better as the main method of diagnosis. RDTs are the main form of diagnosis of malaria by community health workers, although in a few countries microscopies have been trained and deployed in remote areas. Because RDTs require less training and no equipment, they are an ideal diagnostic methods for community health workers. Finally, only microscopy can be used to follow up patients to ensure complete cure, because certain antigens detected by RDTs can persist up to 3 weeks after disappearance of the parasite from the human body. Both RDTs and microscopy must be supported by quality assurance programs. We will review the elements of the quality assurance program later. There are other methods capable of identifying malaria infections. None of these methods is yet recommended by WHO for routine diagnosis of malaria, but they are frequently used as part of research studies or evaluations under research protocols. Polymerase chain reaction, or PCR. This method is able to amplify small fragments of nucleic acids found in the DNA or RNA of malaria parasites. Once these nucleic acids have been amplified sufficiently, they can be detected and in some cases even used to quantify parasite density. They are highly sensitive techniques able to detect even minute quantities of parasite DNA or RNA. However, PCR requires a fairly sophisticated laboratory and personnel who are highly trained in order to generate reliable and accurate results. WHO has initiated an external quality assurance programs for not-for-profit laboratories based in developing countries. External quality assurance panels are distributed twice a year. Loop-mediated isothermal amplification, or LAMP. LAMP is similar to PCR in that it amplifies nucleic acids, but it uses a process that requires less time and less equipment. The training and skill requirements are also fewer than for PCR because of the simplified procedures and equipment. The test platform is more portable than PCR and can be used closer to patients, such as in health facilities with electricity. The same quality assurance programs used for PCR can be applied to LAMP. Serology. Serology can be used to detect past malaria infections through detection of antibodies to the parasite. Serology can provide useful information on past exposure to infections. However, it does not detect current infections and therefore cannot be used as a diagnostic method. While serology may eventually play a role in surveillance for elimination, the procedures have yet to be standardized and validated. Currently, WHO does not recommend routine use of any of these 3 methods, except in specific situations such as the use of PCR to detect Plasmodium knowlesi infections.
We have reviewed the identification of a suspected malaria case and parasitological diagnosis of the case.
we are going to briefly review the WHO recommended treatments for confirmed malaria cases. A patient who presents with symptoms of malaria and a positive parasitological test with microscopy or RDT, but with no features of severe malaria, is defined as having uncomplicated malaria. The clinical objectives of treating uncomplicated malaria are to cure the infection as rapidly as possible and prevent progression to severe disease. Cure is defined as elimination of all parasites from the body. The public health objectives of treatment are to prevent onward transmission of the infection to others and prevent emergence and spread of resistance to antimalarial drugs. For treatment of uncomplicated falciparum infections, artemisinin-based combination therapies, or ACTs, are the treatment of choice for all cases. ACTs are combinations of a rapidly acting artemisinin derivatives with a longer-acting partner drug. The artemisinin component rapidly clears the parasite from the blood, reducing the parasite numbers by a factor of approximately 10,000 in each 48 hours a sexual cycle, and is also active against the sexual stages of the parasite that results in onward transmission to mosquitoes. The longer-acting partner drugs clear the remaining parasites and provides protections against development of resistance to the artemisinin derivative. Partner drugs with longer half-lives also provide a period of post-treatment prophylaxis. There are currently 6 ACTs recommended by WHO and listed on this slide. All of them have pre-qualified manufacturers. The duration of treatment with an ACT is 3 days. In elimination settings, WHO also recommends that treatment for falciparum include a single low dose of primaquine on the first days of treatment to reduce the transmissibility of mature gametocytes. The primaquine reduces the probability of onward transmission. The dosage that is recommended, 0.25 milligram base per kilo body weight, does not cause hemolytic anemia among G6PD deficient persons, and therefore no G6PD testing is required before administration. This is in contrast to the dosage of primaquine used to cure the liver stage parasite of Plasmodium vivax and Plasmodium ovale, for which WHO recommends treatment only after testing shows that the patient is not G6PD deficient. It should be noted that the low dose of primaquine should not be given to children less than 6 months old, pregnant women, or lactating nursing mothers of children less than 6 months old. Several important patient subpopulations, including young children and pregnant women, have special considerations that mean their treatment differs from that of the general population. Pregnant women with uncomplicated P. falciparum malaria should be treated with artemether lumefantrine during the first trimester. Where artemether lumefantrine is not a recommended ACT for uncomplicated malaria or is not available, given the demonstrated poorer outcomes and challenges of adherence to a 7-day course of quinine treatment, the following ACTs may be considered for the first trimester of pregnancy: artesunate amodiaquine, artesunate mefloquine, and dihydroartemisinin piperaquine. Since antifolates are contraindicated in the first trimester of pregnancy, ACTs containing sulfadoxine pyrimethamine are contraindicated in pregnancy during this period. There is currently no documented record on the use of artesunate pyronaridine during the first trimester of pregnancy. The treatment of malaria in the second and third trimester of pregnancy should be with an ACT. Artemisinin derivatives are safe and well tolerated by young children. Therefore, the choice of ACTs is determined largely by the safety and tolerability of the partner drug. Infants weighing less than 5 kg body weight with uncomplicated pre-falciparum malaria should be treated with an ACT at the same target dose as for children weighing 5 kg. Delay in treating Plasmodium falciparum malaria in infants and young children can have fatal consequences, particularly for more severe infections. In treating young children, it is important to ensure accurate dosing and retention of the administered dose, as infants are more likely to vomit or regurgitate antimalaria treatment compared to older children and adults. taste, volume, consistency, and gastrointestinal tolerability are important determinants of whether the child retains the treatment. Mother often needs advice on techniques for drug administration and the importance of administering the drug again if it is regurgitated within 1 hour of administration. Because deterioration in infants can be rapid, the threshold for use of parenteral treatment is much lower.
At times, patients who have recently received treatment for malaria can return to the health facility with a recurrent illness from falciparum. The recurrence can be due to either a reinfection or a recrudescence. It can be very challenging to determine the difference between these two. A reinfection is a new infection, genetically distinct from the first infection. Recrudescence is a recurrence of parasitemia of the same genotype that caused the original illness due to incomplete clearance of asexual parasites after treatment. It can be difficult and at times impossible to differentiate between a reinfection and a recrudescence without genotyping both the initial and the recurrent infection. But an apparent recrudescence should be investigated to try to understand the reason for the treatment failure. The most likely reasons for a recrudescence or treatment failures are vomiting, the medicines before absorption, suboptimal dosing, that is, not prescribing the right dose for the weight or age of the patient, and poor adherence to the full treatment course. Other, but less likely causes of recrudescence are substandard medicines, unusual metabolism, and drug resistance. We will talk about how to systematically and proactively monitor for drug resistance in elimination settings using the integrated drug efficacy surveillance approach later in this module. It is important to note that a recrudescent falciparum infection should be treated with the country's second-line antimalarial medicine.
Treatment of other species of malaria may differ from that of Plasmodium falciparum. If the malaria species is not known, the patient should be treated as if the species were Plasmodium falciparum, because that parasite causes the most severe illness. If the malaria species is known and it is a mixed infection of Plasmodium falciparum and either Plasmodium vivax or Plasmodium ovale, the patient should be treated with an ACT and 14 days of primaquine. Before providing a full therapeutic dose of primaquine, the patient should be first tested for G6PD deficiency. If the patient is infected with Plasmodium vivax, Plasmodium ovale, Plasmodium malariae, or Plasmodium knowlesi, a species of simian malaria that can affect humans, in an area with known chloroquine-sensitive infections, there is an option to treat the patient with either an ACT or chloroquine plus 14 days of primaquine. However, if the parasites in an area are not susceptible to chloroquine, the infection must be treated with an ACT plus 14 days of primaquine. Pregnant women with uncomplicated Plasmodium falciparum malaria should be treated with artemether lumefantrine during the first trimester. There are other options for the treatment, as we have just seen.
Severe malaria can be dangerous to a patient and must be identified and treated immediately to prevent death. For all malaria parasites, severe death is defined as a positive parasitological test for malaria and at least one or more of the signs or symptoms of severe malaria listed in the table. The clinical features of severe malaria include impaired consciousness or coma, prostration, convulsions, acidotic breathing, acute respiratory distress, shock, acute kidney injury, jaundice with vital organ dysfunction, or significant bleeding. The laboratory findings can include hypoglycemia, metabolic acidosis, severe anemia, hemoglobinuria, hyperlactatemia, renal impairment, or pulmonary edema. Hyperparasitemia or high parasite density in infections with Plasmodium falciparum and Plasmodium knowlesi is also a reason to classify a patient as having severe malaria. Death from severe malaria often occurs within hours of admission to a hospital or clinic, so it is essential that therapeutic concentration of a highly effective antimalarial drug be achieved as soon as possible. Management of severe malaria comprises mainly clinical assessment of the patient, specific anti-malaria treatment, additional treatment, and supportive care. Patients with suspected severe disease should be referred as quickly as possible to the nearest referral hospital to ensure appropriate care regardless of age. It is not recommended to wait for a confirmatory diagnosis. Where complete treatment of severe malaria is not possible but injections are available, adults and children should be given a single intramuscular dose of artesunate and referred to an appropriate facility for further care. Where intramuscular artesunate is not available, intramuscular artemether, or if that's not available, intramuscular quinine should be used. When intramuscular injection of artesunate is not available, children under 6 years old can be treated with a single rectal dose of artesunate in suppository form. Children who receive rectal artesunate must be referred immediately to an appropriate facility for further care. Adults and children with severe malaria, including infants, pregnant women in all trimesters, and lactating women, should be treated with intravenous or intramuscular artesunate for at least 24 hours and until they can tolerate oral medication. Once a patient has received at least 24 hours of parenteral therapy and can tolerate oral treatment, the patient therapy should be completed with 3 days of an ACT and a single low dose of primaquine if the infection is due to Plasmodium falciparum. Follow-up post-discharge of patients who have been treated for severe malaria is critical to ensure complete cure and assess for any potential relapse or recrudescence of the malaria parasite.
In settings approaching elimination, supervising the treatment of patients and following them can improve compliance, cure, and contribute to interruption of transmission. Patient follow-up can be organized by scheduling patients to return to their facilities at a future date or by using community health workers to visit patients in their home. Patient follow-up contributes to patient safety by helping to identify any patients who has had a recrudescence or relapse and providing them with appropriate treatment. Patient follow-up also helps to interrupt transmission by ensuring complete cure. We follow up patients at designated time points depending on the parasite species and the anti-malaria drug given. For all species, the first follow-up should be at minimum at day 28 or day 42 after treatment. We use day 28 when the anti-malaria has a shortened half-life, for example, artemether lumefantrine or artesunate SP. We use day 42 when the anti-malaria has a longer half-life, for instance, dihydroartemisinin piperacin or artesunate mefloquine. Additionally, for Plasmodium vivax and Plasmodium ovale, WHO recommends to follow up again at 3 months to check for relapses. In some settings, Plasmodium vivax patients should be followed up to 1 year. At a minimum, all infected individuals should receive a clinical consultation and parasitological evaluation on the last day of follow-up. Because of the long persistence of the antigens used in the RDTs, microscopy must be used for the parasitological evaluation. Patients' follow-up should be documented in their health records and in the National Malaria Database. Patient follow-up should take place for all patients as part of good case management. In a few minutes, we will also talk about how information on patient follow-up can be used as part of a strategy to monitor the effectiveness of anti-malaria medicines.
Up until now, we have been largely referring malaria treatment that occurs within health facilities by trained clinicians. However, in many countries, malaria diagnosis and treatment occurs in the community by trained volunteers. Let's take a few moments to consider how community workers can contribute to malaria elimination. There are potentially several important roles for community workers in malaria elimination. Community workers, abbreviated as CHWs, who have received proper training and supportive supervision, have been shown to be able to use RDTs correctly to rapidly and accurately diagnose malaria infections. Because of their proximity to patients, community workers can provide treatment promptly, preventing the onset of severe disease and onward transmission of the infection.
CHWs can identify patients requiring referral for severe disease and help them to reach the care they need. CHWs can participate in passive and active surveillance of malaria. Through their relationship with the community, CHWs can be advocates for malaria elimination and engage communities to participate in elimination activities. CHWs can also participate in many elimination interventions such as mass drug administration, vector control, case, and focused investigation. In areas where health facility coverage is not optimal, community workers should be empowered, trained, and supported to strengthen malaria elimination efforts.
Treatment supervision and patient follow-up is an important part of case management for malaria in elimination settings. How could the treatment of patients be supervised, and how could patient follow-up be established within the health system of your country? Would you hospitalize patients during their treatment or conduct outpatient supervision? Would you use health facilities or community health workers? How would information be entered into the health information system? In summary, while case management is critical to preventing severe disease and death, in areas approaching elimination, case management also plays a role in contributing to interruption of transmission. Suspected case definitions to identify patients who should be tested for malaria must be constructed to balance sensitivity and specificity and be easy to implement. Microscopy and rapid diagnostic tests are the recommended diagnostic approaches for malaria. Microscopy and RDTs are able to identify clinical illness due to malaria. In area approaching elimination, addition of a single low dose of primaquine for the treatment of Plasmodium falciparum kills mature gametocytes.